Everyone, thanks to the organizers for inviting us. Max and I are going to, we're both clinical epileptologists, so we're neurologists trained in epilepsy, and we're going to tag team this presentation today to tell you about some of our recent work using chronic recordings of brain activity to uncover rhythms of brain activity that help explain seizure timing. These are our disclosures. And just so that we're all on the same page, we'll start with a bit of background, starting with some definitions. So when we say a seizure, we're talking about a typically brief episodic neurological event, which is due to excessive electrical activity in the brain. And seizures can produce altered movement, sensation, experience, and or impairment of consciousness. The term epilepsy we use to denote a chronic, enduring tendency for recurrent unprovoked seizures. And epilepsy among neurological disorders is very common. Only migraine, stroke, and Alzheimer's disease are more common. And it affects a lot of people. So depending on what you read, between 0.5% and 1% of the population has epilepsy. That's between 2 and 3 million people in the US. And the lifetime prevalence of epilepsy is 1 in 26. The causes are myriad. So I like to say that almost anything that's bad for the brain can cause seizures, and that can include strokes and tumors and trauma, among other causes. In thinking about the current clinical paradigm for taking care of patients with epilepsy, it's sort of schematized here. When we sit with our patients, they provide a verbal report of how they're doing, what symptoms their seizures cause, how frequently they're having seizures, and what the timing of their seizures is. And commonly when they report the timing of their seizures, it's seemingly random. And so as clinicians, we do the best we can to apply what's typically a static treatment to reduce the risk of having seizures. For example, taking a medicine twice a day, every day. And that's even though we know that even patients with poorly controlled epilepsy spend a real minority of their time having seizures. By some estimates, less than 0.05% of their time they're having seizures, and the rest of the time is so-called interictal, or in-between seizures. As a field, we're very good at developing new medications for treating seizures. And this graph shows the exponential growth in the number of anticonvulsant medications since the 1880s. But you can also see that we are not that good at moving the needle on the rate of drug-resistant epilepsy, meaning patients for whom medications do not fully control their seizures. That number has stayed disappointingly constant over time, about a third of our patients. And in thinking about the response to serial trials of medications to control seizures, it's really a game of diminishing returns. So about half of patients will respond completely to the first medicine, and a smaller number, maybe 10 or 15%, will respond to the second medicine. By the time you're on your third medicine or multiple medicines in combination, only another 4 or 5% of patients will have their seizures come under control, and that leaves us with this roughly 1/3 of patients who are drug resistant. For those patients, we have to think about something else, and usually they undergo a workup for epilepsy surgery, which means that if we can precisely localize where in the brain their seizures come from, and if that part of the brain is safe to remove surgically, then we might be able to offer that as a treatment. This slide just shows you some of the non-invasive imaging modalities that we use for that process of seizure localization, and some of the invasive techniques like implanting electrodes directly in the brain to record and localize seizures. These invasive recordings are typically done in the acute inpatient setting and last really no more than 2 or 3 weeks because of concern for infection and so forth. We like to do epilepsy surgery when we can, because when it's good, it's very good. So in the best case scenarios, if you remove the seizure producing brain tissue, rates of seizure freedom can be up to 80 or 90%. But surgery is not perfect, and it has limits. That's probably evidenced most famously by this gentleman. This is HM, the most well-studied patient in the history of neuroscience, probably particularly relevant to those of you at MIT. But HM had epilepsy. We think it was related to a history of head trauma, but his seizures came from both temporal lobes. So he underwent an experimental neurosurgical procedure that involved removing a portion of the temporal lobe on each side, which actually helped his epilepsy, but left him with a devastating amnesia syndrome for which he was studied for decades thereafter. So surgery has limits, and for patients who are drug resistant and are not candidates for surgery, we have to think about yet another therapy. And that's when we get to neurostimulation devices. There's a few different technologies that we use for this, but they all have in common the fact that we electrically stimulate the brain without actually removing any tissue. And there's a number of potential mechanisms by which this might help reduce seizures. The list here is not mutually exclusive. But the technology that we're going to be focused on today is schematized here. This is called responsive neurostimulation, or RNS. And this is a device that continuously monitors brain activity. It looks for abnormal patterns of activity, the type of patterns that herald onset of imminent seizures. And it responds to those detections by applying electrical counterstimulation to hopefully normalize the brainwaves. The device itself is shown here. This is made by a company called NeuroPace, and it's called the RNS System. The neurostimulator itself is implanted in the skull, and it's connected to 2 wires that have electrode contacts at the end of them. Those electrodes are implanted in the brain at the site where seizures were found to come from. And the electrodes serve to record neural activity in the form of electrocorticograms, or ECOGs, and they also serve to deliver the electrical stimulation to reduce seizures. In addition to the therapeutic functionality of this device, it also has tremendous diagnostic power because patients can download data about brain activity that's stored by the device to a computer that they have at home and then transmit those recordings to us over the internet. So these are patients who are at home, they're living their life with normal activities, on their medicines, and sending us data that's recorded intracranially over a period of months to years. This is definitely something that is unprecedented in the history of neurology. And it allows us to address some of the things that really weigh heavily on our patients' minds, like the timing of seizures. This is the results of a study that was done, a survey that was done by the Epilepsy Foundation, where they asked over 1,000 patients, of all the things that are bad about epilepsy, what's the worst thing? And of course, there's many bad things, but the #1 response in this survey was actually unpredictability. The simple fact that I can't tell a patient if their next seizure is going to be 5 minutes from now or 5 months from now. It turns out that's incredibly disabling. And people for a long time have been interested in identifying patterns of seizures that might help us anticipate future seizures. This is a study that was published in The Lancet in 1938. The authors were medical superintendents at what was called the Lingfield Epileptic Colony. This was like a residential facility where 110 patients with epilepsy lived. And the authors, over a 10-year period, meticulously charted the incidence of seizures, and they made some interesting observations. They found that some patients tended to have seizures at reliable times of the day, whereas other patients had clusters of seizures separated by regular weekly or multiple weekly intervals. Some patients had monthly patterns, other patients had seasonal variation, and this is all very interesting, but it was purely observational. They didn't really have the tools to try and address what accounted for these periodicities. But we wondered whether the RNS system might be such a tool now 80 years later. Here I'm showing 2 20-second snapshots of brain activity recordings made by the RNS system. On the left, you see a single electrical discharge highlighted in red, and that can be picked up by the RNS system, and you get a count of the number of these discharges. We think these discharges signify electrical irritability of the brain. In the panel on the left, the count would be 1. In the same patient at a different time, a time with more abundant electrical discharges, the count would be, for example, 18. In addition to detection counts of these interictal, between seizure discharges, we also get counts of seizures themselves, and that's in the form of what's called a long episode, which is a prolonged detection of abnormal activity, which for many patients is a reliable proxy for an electrographic seizure. So detection counts of interictal activity and long episodes, which relate to electrographic seizures, are available to us in the form of time series data. And if you look at these data, just the raw data, and you plot detection counts over long periods of time, here's 1 year of data for a female patient and a male patient. What really jumps out of the raw data itself is that the detection counts are not uniform over time. Instead, they fluctuate. They have these oscillations, in this case, on the order of roughly about a month. And the question that we'll talk about next is really how we try to bring some quantitative tools to bear on understanding and analyzing these rhythms. And so Max is going to take over for the next few slides.
So thank you, Vikram. I am going to take over and walk you through this quantitative analysis. The raw data that we have been studying, as Vikram just explained, are those hourly counts of epileptiform discharges that you see here again in blue. And this is the continuous sparking of the brain in between seizures. And we applied a wavelet decomposition to this data to resolve component rhythm, including a circadian rhythm that you see in blue, and multidian rhythm that you see in warm colors. We use the term multidian to explain that these rhythms span over multiple days. And when you combine these multiple days rhythms here in warm colors, you actually can reproduce and reconstruct the envelope of the original signal. In the next slide, I'm going to show you one representative patient, and I want you to focus on the middle panel that is raw data over 1 year of recordings. And you can see that the envelope of this raw data really shows nicely these multidian fluctuations that are quite regular. And if you zoom in over a 2-month period in the middle, you can see the overriding circadian rhythm in addition to this slower oscillation. So now, applying the wavelet transform, we found periodograms with the expected circadian peak at 24 hours and a bigger multidian peak at 26 days in this given gentleman. This is a male patient with temporal epilepsy. And if you look at these orange curves, they underscore these very regular rhythms. Now, doing the math, you can see here that the seizures tend to happen always at in the same phases of this underlying multidian rhythm. And on average, you can see this represented the average by the red dot with the standard deviation. They appear close to the peak. Now, this is, of course, a nice example. Is it true for all patients? Well, in these average periodograms, we found circadian rhythms in all patients at 24 hours and multidian rhythms in all patients, but with individual periodicities. And they're roughly divided into 3 groups: patients with oscillations at about a week and a harmonic component at 2 weeks, patients with rhythms of 3 weeks, and patients with longer rhythms of about a month. The first time that we saw these results, we thought this is all catamenial epilepsy, that is cycles of seizures that are related to menses. But it is not, because these rhythms were found both in males and females with periods ranging from 5 days to 30 days. Thus, the 28-day cycle, the 28-day sexual cycle cannot account for the result. We next asked how stable are these rhythms? And you can see that for any given patient, they are quite robust and they can last for years. In patient number 3, for example, you find the same rhythm recorded at year 1, 3, and 7. So this first finding is very important. The questions that arise here are, what happens when interictal activity is high? How does the patient feel? Is that a bad day for him? What about cognition and mood? Does it fluctuate with those rhythms? And of course, the question that we will address in the next series of slides is, what is the relationship between seizures and interictal activity? Here we can, each row represent a patient, and we are exploring exactly that, the relationship between a full cycle and the timing of seizures. So on the left, you see the circadian cycle over 360 degrees, and you can see that there is preferential circadian time of seizures, but it's anywhere on the left or the right of the peak circadian interictal activity. So again, comparing interictal on top and ictal are the different patients in rows. Now, applying the same analysis to the multidian rhythm, you can see that patients tend to have their seizures in between the upslope and the peak of the underlying circadian rhythm. But remember, circadian spans over 24 hours, whereas multidian, a full cycle, will span over many days, from 5 to 30 in our data. On the next slide, I'm showing you the same data in a compact way in the form of these clock plots, where each hour represents a patient. And again, you can see that some patients have preferential circadian timing of seizures to the trough of the underlying interictal activity, whereas other patients have preferential timing to the peak. On the right, you can see that most patients are between are at the upslope or close to the peak of the multidian interictal activity. Now, combining this circadian and multidian information, we can study seizure risk over time. This is a scatter plot showing you the circadian versus multidian phase, where both axes have been duplicated to show a 720-degree span. And these maps of seizures can be transformed into heat maps to better account for where to chart the territory of areas at risk and areas that are safe for the patient. Now, if you apply the same analysis across patients, you can see that on average, we find cold and hot spots. And if you compare the coldest spots, which would be the light blue, to the hottest spot in yellow, there is an about 16 times factor in difference risk. In the white arrows are overlaid and illustrate the trajectory of a patient with an 8-day multi-DN cycle. So he would start at the middle left on day 1 and day 2 and cross 2 times of increased risk. But then when he arrives at day 5 and 6, he's constantly at increased risk during those 2 days with still an overlaid circadian modulation. And then he continues his journey in days 7 and 8 to close the cycle and start over. On the right, you can see the more conventional forest plots, and you see that the circadian and multi-DN effects are actually additive. And when you combine these 2 rhythms, it accounts for risk ratio in the order of 6 to 7. So I will hand again to Vikram to let you know what perspective this implies.
Okay, so to finish with a few slides, just thinking about the significance of what we've just heard. One of the real beauties of having chronic EEG is that we get to appreciate the dynamics of epileptic brain activity over multiple timescales, ranging from seconds to a minute and looking at individual discharges to days to weeks or even longer, months to years. And it's really with that wider temporal lens that we've been able to appreciate how oscillations on different timescales combine to help determine the risk of having a seizure. I'm always struck by thinking about how similar our results with our patients now are to what Griffiths and Fox reported in 1920, when the periodicities that they found in their patients really resemble what we see in our patients now. But of course, with the advent of technology like chronic EEG, we can look under the hood, as it were, and find out what's going on in the brain at the level of interictal and ictal activity that might help explain these patterns that we see clinically. Thinking back to our clinical treatment paradigm, we imagine that if, in addition to a patient's verbal report, you had access to chronic EEG and knowledge of interictal epileptiform activity rhythms, it might help you reframe a patient's seizure timing. Instead of thinking about the occurrence of seizures along a linear axis, you might do well to think about them along the underlying oscillations that were happening in the background. And perhaps someday, with knowledge of these rhythms, you might be able to change your treatment paradigm to do what's called chronotherapy, which means applying a dynamic, risk-stratified therapeutic intervention to the times when your patient is at highest risk of having a seizure. You can imagine many benefits to this conceptual approach, including cost effectiveness and mitigating side effects during times when patients are at lower risk for having a seizure. The concept of seizure forecasting is also an emerging one in our field. This is really akin to weather forecasting, which is essentially providing a risk of an event happening on a short horizon. So, for example, if I said that the risk of, or the chances of having a thunderstorm tomorrow are 95%, it might allow you to modify your behavior, to pack an umbrella or to change your plans accordingly. And similarly, we think that our patients with epilepsy might benefit from a short horizon seizure risk forecast. In terms of future directions, there's a lot of work that needs to be done, and in some sense, more questions are raised than have been answered. But we're quite focused on applying these findings now prospectively and seeing if we can anticipate seizure risk for patients and how they would do if they were provided that information. For example, through an application on a smartphone that could be used to generate real-time forecasts over some short horizon. And how beneficial would that be for our patients? Or even one question more deep than that, which is, where are these rhythms coming from? What are the drivers of this? What systemic factors or other variables are fluctuating in parallel with what we see at the level of brain activity that might help account for these rhythms? Perhaps if you had understanding of those variables, it might allow you to not only refine your seizure risk forecast, but also potentially develop new therapeutic interventions that take advantage of that information. So that's really where our work now is focused on. And there's a lot of people to thank who've helped along the way with this, and we'll also thank all of you for your attention.